So welcome to our final plenary session and closing ceremonies. My name is Randy Rycroft with the Cancer Data Registry of Idaho and your incoming NAACCR president. I want to welcome you to this final session. I do have a reminder for everyone that we will have a closing network opportunity at 5:30 right outside these doors in the pre-function area. And it'll be your final opportunity to network with your colleagues and get to know some new friends. We will have light appetizers and a cash bar, so stay around for that if you have the opportunity. So I'll be co-moderating this session with Joanne Aitken, and so I will start the festivities and introduce our keynote speaker, Dr. Anil Chaturvedi from the National Cancer Institute, who will be speaking to us about HPV and oral cancers. Dr. Chaturvedi is a senior investigator at the Division of Cancer Epidemiology and Genetics at the U.S. National Cancer Institute. He investigates the molecular epidemiology of head and neck cancer and lung cancer, including the etiology, natural history, prevention, and screening of these cancers. Please help me welcome Dr. Chaturvedi.
Thank you. My thanks to the organizers for the invitation to speak today, and thank you all for being here. I'd like to start with an overview of what I'll cover during my presentation today. I'll briefly review the etiologic role of human papillomaviruses in head and neck cancer. I will then describe why we have come to increasingly care about this disease given rapidly rising incidence for HPV-associated head and neck cancers in recent years. I'll then review the state of the science in terms of what's known about oral HPV epidemiology and the pathogenesis of HPV-associated head and neck cancers. And I'll close my presentation with a review of the tools that we currently have for prevention and screening of these cancers. Now, over the course of my presentation, I'd really like to underscore the critical role that surveillance studies and descriptive epidemiologic studies have played in terms of enhancing our understanding of HPV-associated head and neck cancers. So, human papillomaviruses are small, double-stranded DNA viruses. There are over 140 HPV genotypes recognized to date, and 12 of these are classified as oncogenic HPVs, given their causal role in human cancers. HPVs cause a range of cancers in humans. It is a necessary cause of cervical cancer, causes a vast majority of anal cancers, and a variable proportion of cancers of the penis, the vagina, and the vulva. Across these anatomic sites, two HPV types, HPV 16 and HPV 18, cause a majority of HPV positive cancers, and thus these two types are the primary targets for HPV vaccines. Now, research over the past 20-odd years has identified a subset of head and neck cancers that are associated with HPV infection. These cancers tend to arise from the oropharynx, including the base of tongue, the soft palate, the tonsil masses at the back of the throat, the posterior pharyngeal wall. Now, of all the head and neck cancer anatomic sites, the oropharynx is specifically susceptible to HPV-mediated carcinogenesis, given the abundance of epithelial transition zones in these particular tissue sites. HPV-positive oropharynx cancers, a vast majority of them are caused by one HPV type, HPV type 16, which I just mentioned is the target of the HPV vaccines. When we look at the other head and neck cancer anatomic sites, it is currently thought that HPV has a very low etiologic fraction in causing cancers of the oral cavity and cancers of the larynx. Now, given this, for the remainder of my talk, when I say HPV-associated head and neck cancers, I would be primarily referring to HPV-positive oropharyngeal cancers. So this association of HPV with a subset of head and neck cancers has led to dramatic changes in the population-level epidemiology of head and neck cancers. On this slide, I'm showing you incidence trends for oral cavity cancers in blue and oropharynx cancers in red. These are data from 9 SEER registries covering the years 1973 through 2004. As you can see here, the incidence of cancers of the oral cavity, these are the mouth cancers at the proximal part of the mouth, was approximately stable until about 1984 and has continued to decline at a steady pace since. By contrast, the incidence of oropharyngeal cancers has continued to increase during the same calendar eras, and this increase has been robust, particularly since the year 2000, at a rate of 5% increase in the cancer incidence per year. In subsequent slides, I'll show you how these incidence trends have tracked in more recent time periods. Now, this is in the United States, but it's not a US-specific phenomenon. Similar increases for oropharyngeal cancers have been reported in multiple countries around the world. I'm showing a summary of some of the studies that have been reported from around the world. I know it's a busy slide, but the point I'd like to make here is that these increases for oropharyngeal cancers have been observed primarily in developed countries, economically high-income countries around the world. Now, because these increases happen during an era when the prevalence of smoking, one of the major historical risk factors for oropharyngeal cancers, has been declining, we hypothesized that HPV infection could play a role in this rising incidence. And we conducted a study within 3 residual tissue repositories as part of this year. These are in the registries of Los Angeles, Iowa, and Hawaii. And as part of this study, we went back in time and retrieved archived oropharyngeal cancer formalin-fixed tumor tissues for cancers that occurred during 1984 through 2004. And we used these tissues to test for HPV infection using a variety of sensitive and specific molecular assays. Now, we found in the study that the prevalence of HPV infection in oropharyngeal tissues substantially increased over time. For example, for oropharyngeal cancers that occurred in the mid to late 1980s, about 16% were positive for HPV infection, and this proportion increased to 72% for oropharyngeal cancers that occurred in the early 2000s. And again, a vast majority of these were caused by HPV type 16. Now, because this study was conducted within the SEER RTR repositories, we actually were able to know which were the tumors that were included for HPV testing into our study and which were the tumors that were not. This allowed us to develop a propensity model for selection into this molecular study, and we used the propensity weights to re-weight. What I mean by that is this allowed us to actually take this black incidence trend, which is for overall oropharyngeal cancers, and decompose that into HPV positive oropharyngeal cancers. I'm showing that in red here, and HPV negative oropharyngeal cancers in blue here. And you can see here that this overall increase for oropharyngeal cancers comes exclusively from an increase for HPV positive oropharynx cancers. The incidence of HPV negative oropharyngeal cancers, in fact, declined steadily during the same years, much like the incidence of oral cavity cancers that I showed a few slides ago. So this study showed us that HPV infection is indeed the cause of rising oropharyngeal cancer incidence in the United States. I must note here that similar studies have been reported from Sweden as well as from Australia, and in the intervening years from many countries around the world. So this increase for HPV positive oropharyngeal cancers in terms of the incidence has also led to a shift in the survival for oropharyngeal cancers over time. HPV positive oropharyngeal cancer patients have substantially higher survival when compared to HPV negative oropharyngeal cancer patients. I'm showing you that survival difference on the Kaplan-Meier plot. Excuse me. And given that the proportion of cancers that are caused by HPV has steadily increased from 16% to 72% in the US over time, we've seen that this shift in etiology has led to a substantial increase in the survival of oropharynx cancers as well. So given this emergence of the new entity of oropharynx cancers, the AJCC 8th edition recently adopted novel clinical and pathologic staging systems for these tumors, and the field is actively investigating how best to treat this new patient population. So this increase that I told you for HPV positive oropharynx cancers has not been consistent across all demographic subgroups. On your right, the figure, I'm showing you the age-specific incidence trends. These are age-specific annual percent changes in incidence for oropharynx cancers and for oral cavity cancers. And a negative value indicates that trends have declined, and a positive value indicates that trends have increased. As you can see here, this increase for HPV positive oropharynx cancers has particularly occurred in the 40 to 60-year age groups. This fanning out of heterogeneous age-specific incidence trends is classic for a birth cohort phenomenon. Now, when we look at incidence trends by gender, we see that this increase has occurred almost exclusively in men. Incidence rates have pretty much remained stable in women. So we see this increase for HPV positive oropharynx cancers in young males. So I just said rates are increasing in men, stable or even declining in women. This is in the United States. But when we look at the literature, a very busy table, I'm just trying to make one point here in that, except the United States, the smattering of the literature basically indicates that rates have been increasing in both men and women, which brings to question, is this really a male phenomenon, or what are these conflicting reports? So to understand what's happening here, we collaborated with Freddie Bray's group at IARC to analyze data from the cancer incidence in 5 continents database. And this was done a few years ago, including volumes 6 through 9. We had data from 70 cancer registries encompassing 23 countries. Now, given the cancer registry nature of this data, we did not have any information on either HPV infection or smoking to evaluate mutual roles. So what we did was we compared the incidence patterns for oropharyngeal cancers, which share etiologic associations with HPV, as well as smoking, with those of oral cavity cancers and lung squamous cell carcinomas, which only share etiologic associations with smoking. So I'm showing you results stratified by gender. On this slide, I'm showing you the results for men. I realize it's a busy slide, so let me try my best to walk you through this. I'm showing you the incidence trends, annual percent change in incidence, separately for cancers of the oropharynx in red, oral cavity in blue, and lung in black. A negative value indicates incidence has declined, and a positive value indicates incidence has increased. So a few points regarding these results. Out of the 23 countries, I'm only showing results here for the countries where we have seen an increase for oropharynx cancers. You'll immediately notice these are all, again, economically developed countries. Number 2, in all of these countries, whenever the oropharynx cancer incidence increased in men, it was accompanied by declining incidence rates for oral cavity cancers and for lung cancers, which tells us that smoking cannot explain this increase for oropharynx cancers. And we have interpreted this as a dominant role for HPV vis-a-vis smoking on these incidence trends. So this is in men. Juxtapose that with what we see in women. Again, I'm showing you here all the countries where incidence for oropharynx cancer has increased in women. Again, results for oropharynx, oral cavity, and for lung. You'll see here that almost all the countries where we see an increase for oropharynx cancers in women, it is accompanied by an increase for both oral cavity cancers and for lung cancers. And this tells us that this is a pattern that is very similar to a smoking-associated pattern. And our hypothesis is that the smoking epidemic hit at different cohorts and different time periods in men and women. And when we did these analyses, the women in these countries were still in the throes of the smoking epidemic. So, given that oropharynx cancer has really emerged as one of the fastest rising cancers in men in the United States, we've been tracking this epidemic closely, and we recently did an update of incidence trends through 2015, again using the SEER databases. This analysis again confirmed that oropharynx cancer incidence rates, at least in the United States, have increased primarily in men. Rates have been fairly stable in women. Now, when we look at white men because this is the demographic subgroup that has experienced the greatest increases in incidence over the past 20 or 30 years in the US. So when we look at white men, I'm showing you how these rates have tracked across birth cohorts. So on this figure here, the x-axis is the cohort year of birth, and the y-axis is the cohort rate ratio with the 1940 birth cohort as the reference point. And the fitted lines are fitted joint point regression lines across these rate ratios. So what we see in the United States is the incidence of oropharynx cancers increased substantially in cohorts of individuals born between 1939 and 1955. This is at a rate of 5.3% increase per year. Now, since 1955, there is some good news, or rather silver lining here, in that rates are still increasing for oropharynx cancers, but for individuals born after 1955, this increase has really substantially moderated. So we're looking at the erstwhile increase of 5.3% per year suddenly becoming about 1.7% per year. So what has happened is, in the more recent younger birth cohorts, rates are increasing at a slower pace, but these birth cohorts where they've increased at a much rapid pace are now getting into older ages. So the disease, what I told you was a young male burden, in recent years has started to track along with those birth cohorts, and it is now becoming an older male disease. So when I say older male, I mean ages 65 or even 70 and over in the US. So the epidemic that I described is continuing to evolve, and we are working with Freddie Bray and his group to see how things have changed in other parts of the world. So before moving to the next part of my talk, I'd like to very briefly summarize some of these observations. I've shown you that oropharynx cancer incidence trends have increased substantially in recent decades, and that HPV infection is the cause of this increase. Now, we hypothesize that the changes in sexual behaviors through the sexual revolution and the birth cohorts that went through the sexual revolution experienced increased oral HPV exposure, and this increase is now manifesting as rising cancer incidence. I've shown you that this increase is primarily occurring in men in developed countries, and that this is differential by birth cohort. When we look at the contemporary burden of this disease, it is thought that about 25% of all oropharynx cancers worldwide are caused by HPV, and we see global heterogeneity. High HPV attributable fractions are seen in countries in Northern and Western Europe. In the United States today, over 80% of oropharynx cancers are caused by HPV infection. So while we were doing these molecular epidemiologic studies and tracking these incidence trends, we recognized that further understanding of this disease would need understanding the primary exposure, oral HPV infections. So in collaboration with Maura Gillison, we introduced an oral HPV protocol into NHANES. This is the US National Health and Nutrition Examination Survey. It's a serial cross-sectional representative survey of the US population. And we introduced this protocol for the years 2009 through 2016, 4 cycles. And as part of this oral HPV protocol, excuse me, for individuals aged 14 to 69 years, we collected an oral rinse and tested for the presence of 37 HPV types. So oral HPV infection, when we look at the US population aged 14 to 69 years, about 1 in 14 individuals is infected with any of one of 37 HPV types. 1 in about 30 is infected with an oncogenic HPV type that can cause cancer. And about 1 in 100 is infected with HPV type 16. Oral HPVs are primarily sexually transmitted, and prevalence increases consistently with an increased lifetime number of sexual partners. And when we look at prevalence by age, we see a very atypical pattern in that we see an initial peak at ages 25 to 30, exactly as you would expect for a sexually transmitted infection. But then we see a second peak at ages 55 to 60 years. The reasons for this second peak are not really known. One explanation is that these individuals are the individuals where the cancer is actually increasing. So this could be a reflection of a birth cohort effect. Much like the cancer, the prevalence of oral HPV infection is substantially higher in men compared to women, be it for infection with one of 37 HPV types or for HPV 16 infection. We again don't know the reason for this male predominance. One hypothesis is that men are immunologically more susceptible, and another hypothesis is that transmissibility of the virus is different male to female versus the other way around. So I've summarized the prevalence pattern. Unfortunately, when it comes to the natural history of infection and the pathogenesis, we have very, very few studies that have evaluated this. So we literally do not know what happens between initial establishment of infection and the later development of cancer. Our state of the science today basically shows that we have a good understanding of the risk factors for oral HPV infection and for HPV positive oropharynx cancers. We have decent estimates for prevalence, limited but interpretable estimates for incidence and persistence of infection. Now, we have many unknowns in this natural history. Most importantly, we don't have an HPV-induced precancerous lesion in the oropharynx. We don't know how long it takes from initial infection to cancer. And I told you there's a second peak at older ages. We really don't know the disease relevance of that second peak. Now, part of the reason for all of these unknowns is that it's quite challenging to do these studies, despite all of my presentations saying the cancer is rising at a more rapid pace. Oral HPV infections are rare. 1 in 33 individuals has an oncogenic infection, 1 in 100 with HPV 16 infection. And when we look at the cancers, it increases to 1 in 12,000 odd numbers. So it's really cost prohibitive for us to do these clinical oriented research studies. But we do have strong risk factors. Oral HPV infection confers a greater than 100-fold increased risk of cancer. Sexual behaviors have a double-digit association. Age is a strong risk factor, as are male gender, smoking, and alcohol. So given the availability of these strong risk factors, our group at the NCI recently put together an individualized risk prediction model for oropharynx cancers. This is generalizable and applicable to the US population. So on this table here, I'm showing you a sample calculation for a 46-year-old white male, modest smoking exposure, probably more than a modest drinker, 12 lifetime partners, and is oral HPV, oncogenic oral HPV positive. For this individual, the immediate 1-year risk of development of HPV positive oropharynx cancer is about 0.15%. We have done internal and external validations of this model, and we see very high discrimination and very acceptable calibration. So we now have a risk prediction model. When we apply this to the US population, on this figure, I'm showing you how the cancers are concentrated in the US population. So this is a concentration curve. It's very similar to the Lorenz curve. So when you hear things like 1% of the population owns 99% of the wealth, this is a similar analysis. So on this figure, I'm showing you on the x-axis for all adults in the US population, going from highest model predicted risk to the lowest model predicted risk, and the cumulative proportion of oropharynx cancers, how they are concentrated in the population. You'll see here that 1% of the US population at highest risk accounts for 37% of all oropharynx cancers. 10% of the population at highest risk accounts for close to 80% of cancers. And about a third of the highest risk individuals account for almost all oropharynx cancers. So I told you earlier, if we were to do studies to understand this disease through random selection in the population, the numbers are quite prohibitive. Now, if we use this risk model and we were to recruit individuals, be it in the top 10% of risk or even the top 1% of risk, we can substantially reduce these numbers, and this can really help in identifying high-risk individuals. We don't know what a precancer looks like or how prevalent it is, but we would expect similar efficiencies for finding such a precancer. And we propose that the use of this model can greatly enable research to answer these outstanding research questions. Now, I'd be cautious here in that we generally think of risk prediction models for screening, but we propose to use this only for research studies. Screening is not currently feasible for this disease because there are many, many unanswered questions for screening. We don't have a precancerous lesion. The natural history is poorly characterized. There are many unanswered questions in terms of how do you do the screening? What do you do when you find a high-risk individual? What is the cost effectiveness of screening? So given all of these, we cannot screen for this disease at this time. And the American Dental Association recently came out with a recommendation against routine oral HPV testing in dental offices. So this leaves us with one very promising prevention strategy, which is HPV vaccination. And fortunately, the vaccines work wonderfully well. I'm showing you on this slide results from the NCI Costa Rica vaccine trial of the bivalent HPV vaccine. And 4 years after vaccination, oral HPV prevalence from vaccine types was substantially reduced compared to the control group. So an efficacy estimate of 93%. When we look at the US population in NHANES, if we take individuals who reported receipt of at least one dose of the vaccine and compare them with unvaccinated individuals, this is in young adults, you again see a substantial reduction in prevalence from vaccine types. So the vaccines hold great promise in reducing the burden of this disease, at least in currently eligible populations. So I'd like to close my talk with a very brief summary of what I presented. I've shown you that HPV causes a subset of head and neck cancers that arise from the oropharynx, that the incidence of this disease has increased substantially in recent years. It is caused by HPV infection, primarily in men. We see differential effects by birth cohorts. Cohorts born during the 1930s to 1950s have experienced most of this increase. I told you that unfortunately screening is not currently feasible, but vaccines hold great promise. I'll close there by thanking many of the wonderful individuals I've had the privilege of working with over the years, and thank you all for your attention. We're doing questions at the end? Okay, thank you.
Hello, my name is Joanne Aitken, and it's my great pleasure to introduce Dr. Clarice Joachim from the Registry in Martinique. Is Clarice here today? Oh, good. We hadn't seen you, so we were hoping that you were here. Responsible for cancer research and data analysis of the Registry, implementation of public health studies to evaluate public health risks, tools for epidemiologic surveillance, and decision-making aids for local and national public health authorities. Thank you very much.
Hello, everyone. First of all, as you see, I'm Dr. Clarice Joachim. I am the second name on the study. I am the clinical research associate in charge on all data for patients with prostate cancer. Thank you for inviting me to present our study. This is a study on the survival of patients with prostate cancer in Martinique. We published this study this year in cancer epidemiology. Alors, to introduce, there are higher prostate cancer incidence and mortality rate in Caribbean, and also in Martinique, we are with an incidence at 171 and a mortality at 23. The objective of this study was to analyze overall survival of patients with prostate cancer in Martinique between 2005 and 2014. The population-based study using the data from Martinique Cancer Registry, and we recorded socio-demographic data like years and age of diagnostic, and a clinical variable like clinical stage, PSR level, and Gleason score at diagnostic. 3 localized risk group of recurrence we analyzed: low, intermediate, and high risk. And the second category with regional and metastatic cancer. We analyzed according to 3 age group. You can see there are no pointer. Thank you. And demographic and diagnostic characteristic. We performed overall survival with the Kempler-Meyer method, and we use a Cox model to identify independent prognostic factor overall. We include 5,045 patients with age median at 68, and the median PSA level diagnostic was 10, and clinical stage it was available for 99%. 91% is localized here, and the rest is for general and metastatic cancer. High risk more frequent in the group 65 at 74, more than 75 years. 78 of patients with localized disease were intermediate and high risk. Patients in oldest group had more advanced stage of diagnostic. On the table, you can see the most cases are localized. Yeah. And on this table, you can see the distribution according to age, with most cases in intermediate and high risk. here, here, and for the group age, here, here. On this slide, you can see the Kaplan-Meier, and the 75 years group had worse survival. And on this side, as you suppose, the group of regional metastatic has the worst survival. You can see on this table the percentage of overall survival decrease in the framed group. And the result of Cox model show that the prognostic factor were the age and the high risk group. Despite the higher incidence of prostate cancer in Martinique, prognosis was very good in this patient. As I said before, the Cox model shows us high risk and prostate cancer regional metastatic stage and older age were independent prognostic factor of 4 overall survival. African Caribbean men have the higher risk of prostate cancer. We observed for men diagnosed between 2010 and 2014, 5 years net survival was approaching 100% in Puerto Rico, Martinique, and USA. The molecular and genetic factor need to be analyzed in association with another factor, such as pesticide exposure, family history of prostate cancer, and clinical management. The next step for us will be the quality of life for the patient diagnosticated. If you have any question, you can send an email to Clarisse. And thank you for your attention.
So our next presenter is Dr. Jan Martin van der Schwan from Netherlands Comprehensive Cancer Organization, and he will be presenting on adherence to the Thyroid Cancer Guidelines 2.0 in the Netherlands, guideline evaluation using cancer registry data. Dr. van der Schwan obtained a Master of Science in Health Sciences in International Public Health and started working for the Netherlands Comprehensive Cancer Organization in 2007. He has many publications on the definition of rare cancers, and in 2016 earned a PhD on the surveillance of rare cancers. Currently, he has a position of team manager of research and development with the cancer organization and still carries that strong interest in rare cancers on a national and international level. Please welcome Dr. van der Schwan.
So thank you for this kind introduction. And as I'm standing here at the end of the day, I want to take this opportunity to thank also and send my compliments to the organization for this interesting NAACCR and ICR conference. It must have been a hard work to accomplish this result. And if we consider this as the last day as a big dinner we joined with each other, I think we are now on the dessert. And I was taught that the dessert always remains. So that's good to have you here, and I try to present you some dessert. Thank you for giving me the opportunity to present our work done on the evaluation of the thyroid cancer guideline we did last year. So this is not really an epidemiological overview, but I would like to show how cancer registry data can be of use to improve clinical cancer care via guideline evaluation. In 2015, the evidence-based guideline on thyroid cancer has been updated and was introduced in the year 2016. The update was done modular and by a multidisciplinary team of experts. Childhood thyroid cancer was excluded for this guideline and described separately. I have no conflict of interest. The aim of the guideline evaluation is to understand the possible bottlenecks in the clinical practice of the updated guideline, in the daily clinical practice of the updated guideline. Identify items for follow-up to further improve the thyroid cancer guideline, and to promote the use of the updated thyroid cancer guideline for future purposes. Here you see, I want to give you a short overview on how we work in the Netherlands with the Cancer Registry. I'm working for the Netherlands Comprehensive Cancer Organization, and we are hosting the Netherlands Cancer Registry. The Netherlands Cancer Registry receives its notifications from the National Pathology Archive, and information is mainly retrieved from the pathology reports and patients file. So if there is a notification from the pathology lab, our registry clerks or data managers, they going into the hospital, read the patient's file and get all the information. So the quality of our data is depending on the pathology file and the patient file. I also showed a map. That is where the Netherlands is. It's really in the center of the world. Maybe you're using a different map, but it's in the center of the world, and we are having 17 million inhabitants, and we yearly or annually register around 110,000 cancer cases each year. So. Short overview on thyroid cancer. My interest is in rare cancers, and in the Netherlands, thyroid cancer is still a rare cancer, with 750 cases annually. The male to female ratio 1 to 2.3, and the 5-year relative survival is around 85%. Of course, there is a difference between follicular, papillary, and the group of anaplastic and medullary thyroid cancers. The stage at diagnosis, we see a lot of stage 1 at diagnosis, but also the stage 4 occurs still at moment of diagnosis. So we have an increase, and we have seen many posters and other talks about the increase, but it's not that high as other countries are having at this moment, I think. The guideline evaluation. As a cancer registry and comprehensive cancer organization, we never do such work alone. We work with the clinicians. So they prepare this guideline, they do have the daily practice, and then they have the daily struggle. So we ask them, okay, what are the items you want to check how the guideline is followed? So they identified 6 domains. The first one, cytology reporting following the Bethesda classification, the ultrasound-guided fine needle aspiration cytology, reporting resection characteristics, lymph node picking, iodine dose use after thyroidectomy, and the risk classification. So for the year 2016, we collected additional items within our cancer registry upon the normal items we are collecting to do this evaluation. This is an example of one of the indicators we produced. So this is about the Bethesda indicator, cytology reporting following the Bethesda classification. The quality measure is based on evidence. There is evidence that the Bethesda classification is a valid system to report thyroid cancer cytology. We try to operationalize that to say the percentage of cytological biopsies for which the Bethesda classification was recorded should be an endpoint, and therefore we created the numerator, the number of cytological biopsies for which the Bethesda classification was recorded, and then the denominator, the number of cytological biopsies. And for each of these indicators, we had different inclusion and exclusion criteria. But in this way, we can collect the information from the pathology reports or from the patient's file and measure how the guideline is followed. At the end, you get some simple numbers. And here you can see that the adherence to the guideline is 97%. If we go a bit more into depth, we found that in elderly people, the adherence was lower with 91%, and in the younger people, it was higher. Okay, here we have the adherence to the 6 guideline domains. First, the risk classification was only found in 25% of the MDT reports, and where it was recommended to include it in the MDT report because of clinical decision making. The iodine dose. Low-risk patients should receive low-dose iodine after thyroidectomy. Then the lymph node picking, where it shows a low percentage, that's actually good for lymph node picking when operating thyroid cancer. Because lymph node picking is considered quite invasive for the patient. Then we have the ultrasound guided fine needle aspiration. Was correctly done in 96% and improves the sample result if compared to non-ultrasound fine needle aspiration. And the cytology report, the Bethesda classification, I just already mentioned. Then the lowest score was for reporting the resection characteristics, and there I want to go a bit more in depth. With the clinicians, within the guideline, it was reported that in the surgical report or the report after surgery, these items we are showing here should be in minimal standard to be reported in the report. And for 80% of all the reports, one of those items was missing. Mostly multifocality, then the lymph node presence, and the capsular invasion. So this is what we discuss. We give it back to the clinicians. These are the results, and we go into the country and even abstract it on a hospital level how they are doing and benchmark it with the national numbers. Then a short future perspective. Actually, it is not really a future perspective, it's what we are working on now. We have the guideline evaluation, but we want also to implement it in a correct way. And if possible, this bridge, Pont d'Avion, maybe you know, it's in France, people should be walking up and down from the one part to the other part, back and going forward. So what we are working on, and you also maybe saw it in some ESMO guidelines, that the guideline is translated in clinical decision trees. For some guidelines, it might be difficult to give this clinical decision tree if you're working in a gray area because of expert opinion. But still, if you have these clinical decision trees, you can tap on these figures, and then all the information that was in the paper guideline is behind it. And what if we could add information from the cancer registry directly in those clinical decision decision trees? So if when the doctor is having a patient, he's filling she is filling the characteristics and directly sees what is happening in our cancer registry, what did other clinicians do. But also, if there is new literature available, you might see that clinicians are choosing differently. And then you have the idea that you have to update your guideline. So what we are working on is the decision support tool called OncoGuide. OncoGuide is, you can put it on your tablet, but you can also put it on the screen during your MDT. It's not there for the thyroid cancer, and we are working with a couple of hospitals, but here there is a kind of example for breast cancer. You fill all these characteristics for the patients you are discussing, and on the screen you see what the guideline, the clinical decision tree is proposing, and also the number of cases presented in our cancer registry. At the end, the responsibility to make a decision is for the clinician. The other way around is that if you have this standardized tumor board report, we can directly include the information from those forms into our cancer registry. So it's a win-win situation. At the end, cancer registry data can be of use to identify the level of implementation for the new thyroid cancer guideline. The data collected show that the new thyroid cancer guideline needs further implementation, and there is a great opportunity for cancer registries to continuously monitor and improve the quality of care by using new techniques and direct linkages with patient files. Before ending, of course, I did not do this work on my own. These are the people who supported, and in special I want to thank Annemiek Kwast, our medical advisor from my institute. And some greetings from Utrecht. Thank you.
Thank you very much for that wonderful talk and very entertaining, just what we feel like at this time of the day. I'd now like to introduce our final speaker for the afternoon, Dr. Kathy Cronin. Kathy is Deputy Associate Director for the Surveillance Research Program within the Division of Cancer Control and Population Sciences at the National Cancer Institute. Kathy received her postdoctoral degrees or postgraduate degrees from Cornell University and Johns Hopkins University, and has worked in the surveillance program at NCI and CER registries for over 20 years. This afternoon, Kathy's going to talk to us about racial disparities in the receipt of guideline care and cancer deaths for women and ovarian cancer. Thank you.
Good afternoon. Thank you for the introduction, and thank you for the opportunity to talk about some of our research that we've been doing. And I'll just jump right in. So ovarian cancer is the 9th most common cancer among women in the United States, and it's the 5th most common cause of cancer death. But there are racial differences in survival for ovarian cancer. Black women, 5-year survival is around 39%, while non-Hispanic white women, it's 47.5%. Some of this difference might be related to the stage distribution at the time of diagnosis, but this graph shows the stage distribution for Black women and non-Hispanic white women. The purple bars are for Black women and the green for non-Hispanic white women. There are some differences, but they're really fairly small, with Black women having distant disease 60.3% of the time compared to 58%. And if you look at 5-year survival within stage, you see that Black women have worse survival within every stage. So we know that guideline care has been shown to increase survival. And studies have also shown that many women are not receiving guideline care. And we've also seen that Black women are less likely to receive guideline care than white women. So there was 3 objectives to this study. First, we wanted to describe the use of guideline care in the population. And second, we wanted to investigate factors influencing the receipt of guideline care. And finally, we wanted to understand the role of guideline care in the disparities in survival that we're seeing. So NCI funds patterns of care studies each year in the SERA registries. And the idea is they go out and randomly select cases and then find more detailed treatment information on those randomly selected cases through patient records, also through the physician, and they also find information about the specialty of the physicians. And ovarian cancer was studied in 2002 and 2011. And so the results that I'm going to show here are from those two patterns of care studies, and it's looking at ovarian cancer for stages 2 through 4 for women over 20 that were randomly selected from 14 SEER registries. So we define guideline care based on the National Comprehensive Cancer Network, or the NCC guidelines. And very briefly, we say guideline surgery is debulking surgery, and guideline chemotherapy is multivariate chemotherapy that would include a platinum drug and a taxane. So to do the analysis, we combined data from 2002 to 2011 from the patterns of care studies. And this gave us a sample size of 457 non-Hispanic Black women and 4,617 non-Hispanic white women. If you compare with the white women, Black women were, in the study, were more likely to be younger. They were less likely to be married or partnered, less likely to have private insurance, more likely to have comorbidities, and more likely to have late-stage disease. We were very interested in this study to also look at the effect of consulting with a gynecologic oncologist. And we found that there really wasn't a difference in the consultation rates between white women and Black women in our study. Both groups had a consultation rate of about 60%. So here's a graph showing the percent of women who receive guideline surgery. Let me see if I can. So because we were particularly interested in consultation with a gynecologic oncologist, we just stratified by that variable. So the bars on this side are for people who had a consultation, and on this side are people who don't. And we looked at guideline surgery, other surgery, and no surgery. So these are the results for stage 2 ovarian cancer. And for stage 2, we did not see any significant difference in the receipt of guideline surgery between white and Black women. However, if you did not have a consultation, you were less likely to have guideline surgery and more likely to have no surgery. These are the results for stage 3 cancer. And here we're starting to see difference by race. So among the group that did not have a consultation with the gynecologic oncologist, Black women were less likely to see guideline surgery, and they were more likely to have no surgery. And just like in stage 2, a consultation showed that you were more likely to receive guideline surgery. When we looked at stage 4, there were differences between white and Black women in both groups. So whether or not you consulted with an oncologist, a gynecologic oncologist, Black women were less likely to receive guideline surgery and more likely to receive no surgery. And again, the numbers were higher for guideline surgery if you did have a consultation. For chemotherapy, we looked at women who had any platinum drug or any taxane or both, which is what we considered guideline. And the percent of patients who received both was 61% in non-Hispanic Blacks and 71% in non-Hispanic whites. So that was sort of the data that we observed. We did want to understand a little bit the factors associated with receiving guideline care. So to look at that, we used a multivariate logistic regression. And even when we controlled for other variables that we were able to collect, non-Hispanic white women were more likely to receive guideline care than non-Hispanic Black women. And the standardized percents were 34% for white women and 27.5% for Black women. So that was statistically significantly different. However, it was fairly low for both. And in this multivariate analysis, to be considered to having guideline care, you had to have both guideline surgery and chemotherapy. The factors that were associated with receipt of guideline care were women that were less than 75 years, so younger women, women who had private insurance, had no comorbidities, had early stage disease, and who consulted with a gynecological oncologist. And the standardized percent for people who did and did not have a consultation was 38.4% versus 25.7%. So it did show that people were more likely to get guideline care if they had a consultation, but again, the numbers are pretty low for both groups. We did not see that women treated at a larger teaching hospital was associated with receiving guideline care, but that was after controlling for the other variables in our study. So we also wanted to look at how these factors impacted survival, and that was sort of the main question that we started with. And after controlling, so we did that by looking at a multivariate survival analysis using a Cox proportional hazard model. And after controlling for the other variables in our model, including whether or not a woman received guideline care, race was no longer significantly associated with survival. So the factors that we found to be associated with survival were, of course, the receipt of guideline care, younger ages, women who were married or partnered, private insurance, women who had no comorbidities, women with early stage disease, and even after controlling for whether or not you received guideline care, women who had a consultation with a gynecological oncologist also had better survival. In this case, treatment in a large teaching hospital was associated with better survival as well. So the limitations and conclusions. One, I don't know if I would call it a limitation of study, but I think caution in interpreting the results is that non-guideline care does not necessarily mean inappropriate care, because there's many factors that are influencing the decisions in care that we did not measure. For example, we don't look at patient preferences, we didn't have any data on that, or physician recommendations. We tried to control for comorbidities using a Charleston index, but certainly we didn't control for all the things in the decision process. So I would caution when you're using observational data like this to look at who's receiving guideline care, not to overinterpret it as appropriate versus inappropriate care. So our main result, I think, was that race was not associated with survival after controlling for guideline care for patient and provider characteristics. Black women were less likely to receive guideline care after controlling for patient and provider characteristics. And women who consulted with a gynecological oncologist were more likely to receive guideline care, but the rates were still lower than we would have expected when we started the analysis. So I think the real benefit of a study like this is it shows how important it is to understand why women are not receiving care, since obviously receiving guideline care is going to help their survival and their outcomes. I'd like to thank the registries, the 14 registries that participated in these patterns of care studies. Certainly they did all the hard work of going out and getting the data. I summarized it very quickly, but it has been published and the reference is there if you're interested in reading a little bit more. Thank you.
Thank you to all of our speakers this afternoon, and we now have a couple of minutes for questions. So I'd like to call questions from the floor for all of our speakers this afternoon.
Michelle Coleman, Kathy, I'm standing right next to you, but you're the one I wanted to ask the question. It's a really elegant study, and you showed that when you control for patient and provider characteristics, black women receive guideline care less often, and that there's no difference in survival after you throw guideline compliant treatment into the model. Isn't the conclusion of that the survival deficit that you showed between black and white women is simply the result of black women not getting the appropriate treatment?
I think that is what it implies. It's a little bit hard with observational data to say that conclusion directly, but certainly that is what it appeared in our data, that after you controlled for guideline treatment, the difference in survival did go away.